I'm Gila Netta, a Program Director in Implementation Science at the National Cancer Institute, and I'll be providing an overview of our new request for applications to support specialized centers in global implementation science for equitable cancer control. In this webinar, I will describe, and slides are not advancing. I will describe the goals of this RFA and highlight some of the application details and requirements. We will then have time for questions. So the overarching goal of this RFA is to develop implementation science centers for cancer control in low and middle income countries. Our hope is that these LMIC-based implementation science hubs can serve to not only support a set of investigator-initiated research projects on high priority implementation gaps in cancer control, but also develop research capacity for conducting ongoing implementation studies within LMIC-based academic institutions, clinical and community sites. Given the critical role of practitioners and other stakeholders, we also expect these centers will foster stakeholder engagement between researchers, among researchers, and implementing partners in conducting these studies. And ultimately, we hope to enhance the ability of LMIC institutions to serve as regional hubs for implementation science training and as independent research centers. Just to clarify a few key definitions, implementation science is the study of methods to promote the adoption and integration of evidence-based interventions and policies into routine practice to improve health. The focus is to understand how best to support relevant individuals and organizations or systems to maximize delivery of evidence-based care. For the purpose of this funding opportunity, please note how we are defining LMICs. They can include low-income, lower middle income, or upper middle income countries. Also, please note, because this is a clinical trials optional RFA, please note the NIH definition of a clinical trial as stated in the reference notice here to ensure you are following the appropriate clinical trial submission policies. Each center is expected to have an integrated theme that is addressed throughout the application. So applications would ideally address key priority research areas for the region in which the center is based. Here are some examples of research themes, which could include how to adapt cancer control interventions to an LMIC setting, how to efficiently bundle services, how to effectively integrate cancer control into primary care or other relevant care settings, how to decentralize services to community settings, or how to enhance retention to cancer patients across the continuum of care. And these are just some examples. In addition, each center will propose research projects connected to the overarching theme. In the next section, I will describe in more detail the center structure and components, but for the research projects, here you can see some examples of potential topics for those projects, such as studies to understand barriers and facilitators and characterize the multi-level context, to evaluate implementation processes and co-design strategies to enhance delivery and integration of cancer control services, or to test the cost effectiveness of strategies or test strategies for sustainability and scale up. And again, these are just some examples. So next, I want to tell you a bit more about the application details and requirements. So here you can see the required components for the application. Each U54 specialized center should develop 2 cores and 2 research projects. The administrative and engagement core would support coordination within and collaboration among projects, as well as establish approaches for engaging a broad range of stakeholders in these studies. The research capacity building core could include training and structured mentorship from implementation science experts on the design and conduct of the studies. Additionally, this core could support the development of standardized implementation measures. The U54 mechanism enables NCI and NIH staff to coordinate activities across these centers to facilitate harmonized measures, shared resources, and collaboration across the funded teams. Here are a few additional key components to keep in mind for this RFA. Through this initiative, we aim to encourage transdisciplinary teams of researchers, as well as implementers and other key stakeholders, to develop and test implementation strategies that may be applicable across a diverse range of contexts and populations. Impactful implementation science typically involves and benefits from interdisciplinary collaboration from a variety of fields. So applicant teams should include investigators that provide the necessary expertise to complete the research aims. Further, research projects should be designed to rigorously assess implementation outcomes of the strategies under study. Examples of non-responsive applications are listed in the RFA and also summarized here. So just briefly, this RFA is not intended for applications that focus primarily on testing the efficacy of a new intervention, lack substantive involvement and leadership from an LMIC, proposed trials for therapeutics or diagnostics, proposed certificate or degree programs, or proposed projects that do not address cancer prevention or control. Eligibility criteria are described in detail in section 3 of the RFA, so please do review those. But to highlight a few points, both domestic and non-domestic institutions are, of course, eligible to apply. The PI, or at least one MPI, must be from an LMIC-based institution. And so based at an LMIC-based institution with an appointment there. US-based institutions who apply must have an LMIC-based MPI. And as mentioned earlier, we are defining LMICs according to the World Bank country and lending groups, inclusive of low income, lower middle income, and upper middle income countries. In addition, please note the required registrations listed in the RFA. All registrations must be completed prior to the application being submitted. And registration can take a bit of time, often at least 6 weeks or more. So applicants should begin the registration process as soon as possible. So just a quick reminder on some of these registrations, and apologies if this is going to send your head spinning, but please remember that all of this information is listed in the RFA, but we do want to make sure folks are aware that NIH policy on late submission of grant applications state that failure to complete registrations in advance of a due date is not a valid reason for a late submission. All registrations require that applicants be issued a DUNS number. After obtaining a DUNS number, applicants can begin both the SAM and ERA Commons registrations. The same DUNS number must be used for all registration. Another reminder that SAM registration includes the assignment of a commercial and government entity or CAGE code for domestic institutions, which have not already been assigned one. And similarly for foreign organizations, they must obtain an NCAGE code in lieu of a CAGE code in order to register in SAM. Organizations can register with ERA Commons as they are working through the SAM and grants.gov registration, but all registrations must be in place by the time of submission, as mentioned earlier. And so hopefully that that is a sufficient summary. I will just also mention, so folks can plan in advance, that applicants must complete and maintain an active registration, which requires renewal at least annually. And the renewal process may require as much time as the initial registration. So please plan accordingly. So also just briefly wanted to mention that we are requesting a letter of intent, not required, but it does help us estimate the review workload and plan for review. And this is due October 8th. It's very limited information that we're asking for, simply a descriptive title of the proposed activity. You are allowed to change that title if desired, but this will help us give us an idea of what the overall goal of the project is with this title, the names, addresses, telephone numbers of the PVs, PIs, a list of the key personnel and participating institutions. And also if you could just reference the number and title of this funding opportunity, and those can be emailed directly to me. So we encourage you to carefully read through the review criteria listed in the funding announcement. Here we paraphrase and highlight some of the review criteria. Applicants should demonstrate strong partnerships and a history of collaboration, as well as have implementation science expertise on their team. Applicants must address a high priority implementation gap in cancer control and use appropriate implementation science approaches in their research design. To say a little bit about the U54 mechanism and the nature of the cooperative agreement in terms of the roles of the PI versus the NCI or NIH staff. The U54 is a funding mechanism used when there will be substantial federal scientific or programmatic involvement. And substantial involvement means that after the award, NIH scientific or program staff can assist, guide, coordinate, or participate in project activities. So under the cooperative agreement, the role of the NIH is to work in partnership with the award recipients to support and stimulate their research. It is not to assume direction, prime responsibility, or a dominant role in the activities. So consistent with this concept, the dominant role and prime responsibilities reside with the awardees for the project. And here you can see on the table some examples of what these primary responsibilities are. So for the PIs, their prime responsibility is defining the research objectives and objectives of the center and approaches, including the study design and protocol development and the course, overseeing the conduct of the center and the studies, including data analyses and interpretation, quality control, et cetera, and publication. Also cooperating with NCI and NIH programmatic, technical and administrative staff, and of course, administratively managing the U54 Center. Awardees will retain custody of and have primary rights to the data and software developed under these awards, subject to government rights of access consistent with current DHHS, PHS, and NIH policies. And investigators are encouraged to organize and participate in joint meetings and workshops, organize collaborative activities, and participate in scientific working groups. NCI and NIH staff will have substantial programmatic involvement that is above and beyond the normal stewardship role in awards, as described here. So monitoring the progress and performance of the awardees, typically done, but also participating in activities of a program steering committee. We anticipate there will be a steering committee for this broader consortium, facilitating collaborations among the awardees, and potentially also with other NCI-sponsored programs, reviewing all major transitional changes, of course, and then providing technical assistance as appropriate.
U.S. Department of Health and Human Services, National Institutes of Health, National Cancer Institute, cancer.gov, 1-800-4-CANCER.